I'll be giving the Emergency Critical Care Medicine Conference lecture. I'd like to thank Dr. Anthony, Dr. Buckridge, Dr. Beta, Dr. Kim, and Dr. D'Souza for helping me out. Starting with a case, an EMS notification for sepsis. This is the pre-hospital history. We have a 78-year-old woman found slumped on the couch, unresponsive, last seen at baseline 3 hours prior to arrival. She's warm to touch on EMS arrival, episode of vomiting and stool incontinence en route. Here are the EMS vitals. She has a heart rate of 119 and she's satting 100% via BVM. So the initial assessment. So the airway is intact, the breathing is agonal, and she's being assisted with a BVM. She has good distal pulses with a prolonged cap refill. She's lethargic, ANO times 0, and she feels warm to touch. These are the triage vital signs. So she's tachy, her blood pressure is 96/60, and her temperature is 104.2 orally. So, what is our what are our problems so far? Anyone could shout it out? Okay, sepsis or fever. Perfect. Another one. Okay. Perfect. So altered mental status, fever, hyperthermia, tachycardia, hypertension, and an episode of vomiting. So what are the initial interventions that you guys want to do for this patient? Given in mind that she's being bagged, she's altered, and okay, IV. So you're gonna get your IVs, cardiac monitors, EKG, and rectal temperature. So this is the HPI per attending's note, a 78-year-old female with hypertension, hyperlipidemia, CVA with right-sided residual deficits. She's brought in by EMS for unresponsiveness. Last known well was around 2:30 p.m., found at home with altered mental status at around 3:30 p.m. There's no other history available. These are the list of her medications. She's on a losartan, simvastatin, and aspirin. And per EMS, she was brought from home and lives with family. There's no family in the ED to provide further information. On your physical exam, she looks lethargic, toxic appearing, and diaphoretic. She has dry mucous membranes with no signs of head trauma, shallow breathing, agonal. She's tachycardic with a normal S1, S2. Her abdomen is soft and she feels warm with no peripheral edema. Neurologically, she's ANO times 0, nonverbal, and her right upper extremity is contracted. So what are the differentials? What are the differential diagnoses at this point? What do you guys think of? Sepsis, perfect. Only sepsis? Heat stroke, wow. It's great. What else? So sepsis and heat stroke? Neuroleptic malignant. So basically neurological, you can think of meningitis, infections, you can think of endocrine pathologies, thyroid storms, pheochromocytoma, malignant hyperthermia, serotonin syndrome, and obviously a heat stroke. So upon reassessment, patient rectal temperature is 109.2, her heart rate is 97, and her blood pressure is 82/62. Okay, so this is the EKG. Exciting. In terms of ED course, soon after arrival, the patient was intubated. She was given etomidate 20 and 80 a froc. Tube was placed and NG tube was placed and she was given 6 milligrams of Versed. Immediately after intubation, the cooling process started. Initially, bags filled with ice were placed all over the patient. And then the patient was covered with wet blankets. Afterwards, she was placed in a body bag filled with ice and water. Fluid bolus was given and repeat temperature improved to 104 within the first hour of patient arrival. This patient was in CCT, by the way. Presidex was selected as post-intubation sedation. And she was given also a broad spectrum antibiotics and given Tylenol 650 milligrams rectally. So what test do you want at this point? CT head, okay. Anything specific? I just want to hear one thing. Okay, perfect. Any other labs results that you're curious about? We were just talking about it. You were just mentioning it, your CK. Okay, so you ordered your basic labs, your CK, you added your blood cultures, and you got a CT head and a chest x-ray, and you obviously placed a consult for critical care. So here are the results. The pH is 7. This is a post-intubation blood gas. pH is 7.2 and a lactate of 2.9. These are her labs. Her gap is 16. And her hemoglobin is 77.8 and her platelets are 1.5. These are the rest of her labs. So she has a trope of 0.03 and a CK of 1,343. She is COVID negative. During her ED stay, patient had 2 episodes of tachycardia to the 160s, documented as narrow complex with no P waves and terminated with carotid massage with no rhythm strip available. She was also noted to be like persistently, her blood pressures were soft, her maps were around the 62s, a central line and an A line were placed, and she was also given potassium and mag repletion. This is the chest x-ray. It was read as CHF versus fluid overload and possible large lucency in the right side. And Mickey also recommended a CT chest for this finding. This is her head CT. So it showed an old infarct with no acute pathology. And this is her CT chest that was also done in the ED. It showed bilateral pleural effusions, right worse than left, and a concern for pulmonary trunk of 4.5 centimeters, suggesting pulmonary artery hypertension. So far, what is our, after all these diagnostics, what are updated problem list? Okay, so patient is still hyperthermic, respiratory insufficiency, she has hypokalemia, she's anemic, thrombocytopenic, and per the CT chest, she has bilateral pleural effusions. This is a critical care consult. So they basically just recommend continued cooling and repletion of electrolytes. So this brings us to my talk of heat stroke. It essentially occurs either from exertional or passive heat exposure during heat waves. We'll touch on other causes of hyperthermia, but it won't be the focus of this talk. With that kept in mind, keep your differential wide when dealing with such cases. So fever versus hyperthermia. So hyperthermia is defined as elevation of core body temperature above the normal diurnal range due to failure of thermoregulation. In literature, it describes those conditions that increase the body temperature above that set by the hypothalamus and involve complete loss of thermal control. And usually the temperature is high, very high, more than 105 or 40 Celsius. In contrast, fever is caused by the hypothalamic activation in response to cytokines. Such cytokines can be triggered by infection or sterile inflammation. In terms of classification of heat-related illnesses, exists along a continuum spectrum from less severe symptoms of heat edema and heat cramps to potentially fatal heat stroke. Heat edema are benign, self-limited condition in response to heat exposure, causing vasodilation of the extremities. And these patients can be simply managed on site with moving the patient to cooler weather. Heat exhaustion occurs with increasing cardiac output in response to heat exposure, resulting in tachycardia, profuse sweating, vomiting, without any CNS involvement. In heat exhaustion, you can have elevated or a normal core temperature. There's other classifications of heat-related illnesses that exist in literature. This is the Japanese Association of Acute Medicine, and they published this criteria for heat-related illness, including heat stroke, and they basically classified it as from stage 1 to stage 3. They took into consideration hepatic and renal dysfunction and coagulation disorders, and they apparently did not include the temperature in their diagnostic criteria. So heat stroke, it's clinically defined on the basis of a temperature more than 40, neurological manifestations with altered mental status, ataxia and seizures, and multi-organ failure in the setting of a large environmental heat load. So heat strokes are classified either exertional or non-exertional. The classic heat strokes, which are the non-exertional heat strokes, result from passive exposure to extreme environmental heat, secondary to impaired mechanism of heat dissipation or inability to escape a heated environment. It tends to occur in epidemics, during heat waves, and might be your older, frail patient with limited mobility that's living in a non-conditioned apartment. It develops slowly and it takes time to develop. On the other hand, exertional heat strokes, they're generally obvious based on the history associated with participation in sports and outdoor activities, resulting in excessive production of metabolic heat that will eventually overwhelm physiological heat loss mechanisms. They tend to occur rapidly and fast. A bit of background information. So the average of 702 heat-related deaths yearly in the United States, and it's likely underreported. That's in contrast to around 1,500 hypothermic-related deaths in the US. So it's it's less commonly seen in clinical practice, and death is highest amongst male patients, and risk factor include elderly, alcoholism, mental illness, and homelessness. But with global warming and rising temperature, climate models predict an increased frequency and severity of heat waves and incidence of heat strokes. In terms of pathophys, the mechanisms result from imbalance between heat production and heat dissipation. Heat dissipation is achieved through four major mechanisms, either evaporation, conduction, convection, and radiation, and that will occur with passive transfer of heat from the skin, either from direct contact between surfaces or by moving liquids and gas, such as blood flow to the surrounding tissues. The response to heat stress is coordinated by the hypothalamus. The primary mechanism of heat strokes involves a transition from a compensatory phase to compensable phase to a non-compensable phase. The first is the non-compensable phase, and as the body temperature increases, sympathetic vasodilation increases blood flow to the skin, resulting in sweat. This leads to a relative reduction in intravascular volume and loss of electrolyte. If continued, it will result in increased cardiac output and redistribution of blood flow via shunting from the central and visceral circulation to the skin and muscles. If continued, this leads to a non-compensable phase, and the compensatory mechanism fails. Central venous blood pressure will drop, and the body ensues in a SIRS-like response, with ultimately resulting in circulatory collapse and multi-organ failure. On a cellular level, this causes denaturation of proteins and release of pro-inflammatory mediators and heat shock proteins. Together, these processes can lead to activation of the coagulation cascades and ultimately results in DIC and multi-organ failure. So how do we manage these patients in the ED? So the key concept to keep in mind when managing these patients is, number one, early recognition. Early recognition and early resuscitation is key, and that is maintained by a high clinical suspicion and weather awareness, especially during heat waves. Number two, rapid cooling techniques, for which we'll discuss. And the third thing is treatment of complications and constant reassessments and aggressive supportive care with emphasis on your ABCs. Just to go to airway and breathing once more, early intubation is indicated in patients with heat stroke, as our patient. When preparing for intubation, both ROC and SUCS have been used in patients with heat stroke. There's a theoretical basis to support the use of a non-depolarizing agent such as rocuronium in terms of avoiding possible heat generations during fasciculations, plus an added benefit of a longer half-life with ROC, and it might reduce the metabolic heat generation. Avoid SUCS as it may worsen hyper-K, and that is common, especially in exertional heat stroke. It also may confuse matters later regarding the possibility of a malignant hyperthermia. As of now, the benefit is theoretical, and there is no clear evidence supporting either use of ROC versus SUCS. Sedation is also important, regardless of the intubation status. Ongoing agitation must be avoided in these patients. Muscular exertion can increase the risk of rhabdo. Benzos, ketamine, and Presidex are all great options for both sedation and treatment of shivering during the cooling process. Regarding circulation, hypotension in these patients usually responds well to volume expansion and cooling. Shock, vasodilatory shock, and primary myocardial dysfunction may underline sustained hypotension. When selecting your pressor, consider the use of a vasoactive catecholamine, such as dopamine or dobutamine. Inotropes that cause vasoconstriction, such as levo, may impede cooling by redirecting blood flow away from the skin. To date, there's no prospective comparable studies that have confirmed the efficacy of targeted fluid administration or specific vasoactive drug in heat strokes. Ideally, patients should be placed on a continuous temperature monitoring. We must be careful not to overcool these patients and induce hypothermia. Monitoring should be continued for around 6 hours after thermal instability. Regarding our temperature goal, there's no evidence to support a specific temperature goal or endpoint, but rectal temperature of around 38 to 39 Celsius reported in large case series as a safe endpoint. Regarding temperature measurement and monitoring, there's a couple of invasive versus non-invasive techniques. The pulmonary artery via Swan gas is considered the most accurate. Rectal temperature is considered the most practical way, and that's what we use mostly in the emergency. Esophageal probes can be also done, and they're very accurate. They'll be done in obviously intubated patients. This prospective cohort study was done in 42 ICU patients, comparing PA catheter to others, and it basically found that measurements of bladder, rectal, and it found that urinary bladder esophageal thermometers are more reliable than the rectal thermometers. This study is pretty small, and I could not find any strong evidence to support the use of one measurement over the other, but given the practicality, rectal probe in the ED is definitely not a wrong choice. So how do we actually cool these patients? 3 different cooling techniques: surface cooling, internal cooling, and respiratory cooling. Currently, only physical methods of cooling are recommended, and there's no evidence to support one over the other. A systematic review in 2007 showed no definite data to guide specific cooling approach. All these techniques are intended to be initiated immediately and simultaneously, keeping in mind your resources and capabilities at where you work. First, surface cooling. So it consists of immersive ice baths, evaporative cooling, and external pad cooling systems. Cold immersion is considered the gold standard, a class 1A recommendations from the Wilderness Medicine Society in heat stroke patients. Ideally, filling a bath of water with ice, filling a bath with water and ice, and allowing water to reach 0 degrees prior to patient immersion. This is often set up near marathons and in anticipation of exertional heat strokes. Water plays an important role with maximizing the body surface area and contact during the cooling. Simply placing ice cubes on the patient body will not achieve that. Alternatively, in the ED, placing a patient in a body bag and filling the body bag with ice and water, also known as the TARP taco technique, has been described, but there's no statistical difference between ice water versus cold water immersion. In terms of the pros, it's a very effective way of cooling, but it's poorly tolerated. It's very labor intensive, and it obstructs the resuscitative measures. Then we have evaporative cooling. So mist fan technique is done, and that's by removing patient's clothing, spraying cool water on the patient's body, and directing a fan over the patient to facilitate evaporation. It is practical and comfortable for the patient compared with other methods. This method is widely used in hot summers in Saudi Arabia, and it's called the Mecca cooling unit. It's used to treat pilgrims during Hajj and large mass gathering during summer. Then we have our external pads. We have this available in the CCT. We have the Stryker temperature control device and surface pads. And upstairs in the MICU, they have the cooling devices that are used for therapeutic hypothermia and post-cardiac arrest patients. So this graph was from a systematic review that pulled around 63 studies and compared cooling rates among different cooling techniques. Over on the left side is the cold water immersion, all the way to all these other different techniques, including evaporation, cold pack placement. And it concluded that water immersion techniques effectively lowered body temperature faster when compared with passive cooling in hyperthermic patients. There were several limitations in the study, and the amount of evidence for heat stroke is still limited. However, this conclusion was described by the author as having a very low certainty of evidence, and so as many of the studies on hyperthermia, the evidence is pretty limited. The other way of cooling is internal cooling. Each liter of chilled crystalloids will cool the patient by roughly 1 Celsius. Not well studied in hyperthermia. This study compared administration of 40 cc's per kgs of cold versus room temperature normal saline, and they measured the core temperature 30 minutes after infusion. And the results are shown in this graph. Both resulted in cooling. The temperature gradient is about twice as large with cooled fluid. So this is double the effect. This was in anesthetized patients, not in heat stroke patients. Here, the limitation would be large amounts of fluid needed in hyperthermia and the time needed for fluids to be infused. Another way of internal cooling is intravascular balloon catheter systems. And we don't carry this in the emergency. It's upstairs in the NICU. These intravascular cooling catheters have been approved for therapeutic cooling and rewarming. However, a few case reports few cases have reported in intravascular cooling for heat stroke. This was published in 2015. They reported for the first time a good recovery in a case of severe heat stroke, which was successfully treated through initial intravascular cooling. It was a 39-year-old male who presented with a temperature of 41. And within 32 minutes of arrival, his core temperature was around 38.8. Other methods that I would describe is respiratory cooling. These are all adjunctives and not to be taken solely. Dry air can be done via nasal cannula. You can put on a very high liter. You should put air, not oxygen, just to not over-oxygenate these patients with hyperoxia. You can also place a nasal CPAP and adjust the FiO2 and put it on a flow rate of 20 to 40 liters per minute. Other techniques such as gastric, bladder, and rectal lavage lack quality human research and are associated with significant side effects. They're unlikely to be more effective than external cooling measures. Pharmacological agents have also been tried. Dantrolene has been considered. This agent was found ineffective in double-blinded randomized studies. At this time, no pharmacological agents have been found to be effective in cooling patients with heat stroke. There is no role of antipyretics, as the underlying mechanism of heat stroke does not involve change in the hypothalamic set points. So regarding the complications, many are reversible with cooling. Many patients can suffer from long-term neurological and functional impairment. There's a European prospective study of 83 patients found that a 2-year mortality approached the 71% of most patients, and patients that survived had significant functional impairment. Combination of muscle injuries, volume depletion, and the AKI can lead to rhabdo. Treatment involves cooling and aggressive fluid administrations. Thermal injury to the liver is a common finding in heat stroke. They may peak 24 to 72 hours after the thermal insult, and it's attributed to the central lobular necrosis. Hepatic damage is almost always reversible with a full recovery, but patients with acute liver injury may require transfer to a liver transplant capable center. Going back to our patient, the inpatient course. So on the first day, her MAPs were around the 75. Her temperature was 98.1. Intubated, ventilated, and she was started on Vanc, ceftriaxone, ampicillin, and acyclovir to rule out meningitis. On day 2, she was extubated, and she was started dopamine 2 micrograms per kg per minute, and the urine culture showed no growth. Blood cultures showed gram-negative rods. On hospital day 3, The patient is more alert and she's following commands. Dopamine was DC'd and metronidazole was added per IDRX for possible blood culture that were going bacillus. Neuro IR did an LP on this patient, and the LP was negative. And on day 4, she was more alert following commands. MRI and EEGs were also pending. On hospital day 5, central lines and arterial lines were pulled, and the EEG was unremarkable for seizures. Hospital day 9, she was transferred to the floor with continued feeding and a plan for a PEG tube placement. And on hospital day 14, the patient was ALAC and discharged pending social work discharge. So in summary, early cooling improves the morbidity and mortality. Most accessible cooling techniques in our ED is going to be filling a body bag with ice and water. All hands on deck. Our ice machines are not the fastest and they don't always work. So get the techs, students, and attendings to grab as much ice and water as possible. And here are my references.